It is a beautiful morning at the end of May. We've had rain for days and days, and I can see the sun. So, Dr. Debbie Morris here to finish talking about renal physiology and to apply what we have learned in these two lectures to a couple of cases before we dive into acid base physiology, which is going to be an extremely important part of the course, if not the most important in some ways. So, we're going to first really do a quick run through to review the material in the previous lecture. We're going to go into a little bit more detail about the endocrine functions of the kidney, talk about something we've touched on several times, which is how the kidney interacts with other systems like the cardiovascular system and the nervous system and the endocrine system to regulate fluid volume. And then finally, talk about some kidney diseases and how they relate to renal physiology. So let's review. We have two kidneys. They are located in the retroperitoneum at the costovertebral junction, sort of the thoracolumbar junction near the vertebra. They each has about 500,000 glomeruli because the renal artery divides into about 1 million arterioles, so 500,000 in each side. And this provides actually significant excess capacity, which means that we can have a fair amount of renal damage or renal disease and continue to live normally. If you are in an unfortunate accident and get stabbed in the back at the bar and lose a kidney, or get knocked off your motorcycle and lose a kidney, you'll be just fine because one kidney, even though we have dropped your capacity of 500,000 glomeruli, that kidney is going to be able to take over and do a perfectly good job of filtering and the other functions of the kidney. Remember that there is a single renal artery and a single renal vein. So the blood enters through the renal artery and leaves through the renal vein. But the third tube coming out of the center of the kidney is the ureter. And all of the urine that is collected, that is produced within the structure of the kidney, is collected in the renal pelvis and then goes to the bladder through the ureter. There's a capsule, a cortex. The renal medulla is organized into something called pyramids. Those pyramids have what appear to be rays, which are the tubules along with the vasorecti, so the tubules of the glomeruli, especially the loop of Henle for the juxtaglomerular nephrons. And between the pyramids are something called columns. So the processes that the kidney performs include filtration, and that's what happens at the glomerulus. Fluid is taken out of the plasma, out of the bloodstream, and pushed into the urinary space. And the filtrate that is pushed by the forces that we've talked about out of the plasma and into the urinary space contains water and small molecules and has the same osmolality as serum. So if serum osmolality is about 300, the osmolality of the filtrate as it is collected in Bowman space is about 300. As that filtrate moves through the nephrons, lots of things are reabsorbed, and that reabsorption occurs in the tubules, and then in those tubules would be the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and then the collecting tubules and the collecting ducts continue to provide reabsorption. So there are a lot of things reabsorbed, almost all of the water, almost all of the sodium chloride or salt. Under normal circumstances, all of the glucose, all of the protein and amino acids, and then varying amounts of other substance according to the needs of the body to maintain homeostasis, which is true for all of these substances. And that would include things like calcium and phosphate, potassium, hydrogen ions. These are important items that are regulated by the kidney. And then there is active movement of some substances from the peritubular capillaries, which, if you remember, are branches of the efferent arteriole, and that are moved back into the tubular fluid through a couple of mechanisms: active transport, passive diffusion. And among those things that are secreted are hydrogen ions when the kidney is needing to regulate hydrogen ion concentration, creatinine, which is another waste product of protein metabolism. Many drugs are secreted. They may be filtered, but many drugs are also secreted, and some other ions may be secreted. So the kidney has an enormous number of functions to maintain the health of the body. One at the top, I'm going to put that it maintains homeostasis of volume of salt and water. Okay, so we take in more water than we need most of the time. We take in more salt than we need most of the time. The kidney makes sure that we don't blow up into great big saltwater balloons. It certainly participates using the same mechanisms in volume control. So the volume of blood um, is is regulated by the kidney under the influence of a number of other systems. Also, blood pressure. The kidney is not the only input into blood pressure, but it is a significant input into blood pressure. The kidneys regulate osmolarity, again in conjunction with other systems like the central nervous system and the hypothalamus. It controls the concentration of lots of different ions in the blood, and calcium and phosphate are among those, especially calcium, which is very tightly regulated. It eliminates waste products such as urea and creatinine and certain other toxins. And then the kidney functions as a gland, as an endocrine organ, and it makes some hormones that are really crucial. Renin, which is the first leg in that renin-angiotensin-aldosterone system. Erythropoietin, which is a growth factor that acts on red blood cell precursors in the bone marrow, and activated the active form of vitamin D, which is a hormone called calcitriol, also called 125 dihydroxy vitamin D3. And then finally, I'll say last but not least, the kidneys participate very actively in the homeostasis of the acid base balance by either eliminating or holding on to or even creating hydrogen ions, and the same with bicarbonate ions. So, by managing hydrogen and bicarbonate, the kidney helps us to maintain a normal pH. You remember that the glomerulus is essentially a tuft of fenestrated capillaries. Those capillaries, which have their single wall of epithelium, are actually surrounded by other cells that are called podocytes that provide a positive charge that keeps certain substances from leaving the plasma. They are attached within the glomerulus by a matrix of cells that are called the mesangial cells. The tuft of capillaries is sitting within a space lined by epithelium. So remember, capillaries are endothelium. So within the space lined by epithelium, that is called Bowman's space or the urinary space. And here we're showing the podocytes and the foot processes surrounding the capillaries, which I had mentioned earlier. And there is a basement membrane that surrounds the capillary. This is a non-cellular structure, but is part of the filtering mechanism. It is supplied by an incoming arteriole, which we will call the afferent arteriole, incoming. And it is the blood from this capillary tuft. It recollects and leaves by the efferent arteriole. And it is the urinary space in Bowman's capsule is continuous with an epithelium of the proximal convoluted tubule. The epithelial cells that line the proximal convoluted tubule are called a brush border because they have lots and lots of microvilli. And then the distal tubule actually, again, comes very close to the glomerulus. The fluid that filters out of plasma into Bowman's space is in volume in a healthy individual about 125 milliliters per minute. The filtration is powered by the pressure differential between the capillaries and Bowman's space. There are forces there are forces that promote filtration and forces that oppose filtration. If you remember, blood pressure promotes filtration. The pressure in Bowman's space opposes filtration. And the plasma oncotic pressure created by proteins in the plasma opposes filtration. And the net filtration pressure is the blood pressure in the capillary minus the two opposing forces, the pressure in Bowman's space and the oncotic pressure. That filtrate as it enters Bowman's space is mostly water, but dissolved in the water clearly are all of the electrolytes that are in plasma. So sodium and potassium and chloride and calcium and phosphate and magnesium and all of the other electrolytes. Glucose, because it's a small molecule without a charge. Urea, the same, small molecule without a charge. Other small molecules. There's very little protein, very little amino acids because they are stopped at the podocytes. This filtrate from Bowman's space moves into the distal convoluted tubule and through the nephron. And as it moves through the tubules of the nephron, and where there are different concentrations of pumps and channels, it changes its composition because some things are reabsorbed and returned back into the plasma, into the blood. Some things are secreted and move from the capillary into the tubule. And so as the fluid moves along the nephron, its composition changes, its osmolarity changes up and down both, and its volume diminishes. So as we're proceeding through the nephron, the volume diminishes, and how much the volume diminishes is tightly controlled. Just again a reminder that there are two types of nephrons. All of the glomeruli are in the cortex, but the cortical nephrons are mostly in the cortex, with the loop of Henle being relatively short and only extending a small way into the medulla, while the juxtamedullary nephrons have much longer loops of Henle, have their capillaries and arterioles, capillaries, and venules organized into these things called vasa recta that extend deep into the medulla. There, the vessels run along the corticomedullary junction, the larger vessels. So again, leaving Bowman's space and starting at the proximal convoluted tubule, the cells that line that tubule are a cuboidal epithelium with a large surface area. So we call it a brush border, lots of villi. And in the proximal convoluted tubule, we have lots of sodium being reabsorbed into the capillaries. Now, sodium is transported in out of the cell, out of the epithelial cell, on the basilar side by the sodium potassium ATPase. It is being absorbed into the cell on the apical side, in most cases through secondary active transport, along with other substances like glucose, chloride, hydrogen ions in either co-transporters or counter-transporters. So lots of sodium leaves the lumen, enters the cell, is pumped out of the cell on the basilar side by the sodium potassium ATPase and re-enters the extracellular fluid and ultimately the intravascular space if required. So water follows that salt. For all of the salt that is removed, some water is removed. There are co-transporters on the brush border that are removing all of the glucose and all of the amino acids. And those co-transporters, particularly glucose transporters, are finite in number. And if the amount of glucose in the filtrate exceeds the ability of those co-transporters to move it back into the cells and then out on the other side, you'll end up with some glucose in the urine. And that has some consequences. If you think about it, glucose is an osmotically active substance. Each glucose molecule is one osmotic particle. And so if glucose is staying in the filtrate, water stays with it because water is going to be moving to maintain appropriate osmolarity. Not most, but a lot of the potassium is reabsorbed here and it's reabsorbed passively. There are some drugs secreted at the proximal convoluted tubule from the capillaries into the tubular fluid. And then and this is an important point, there is H2CO3, right? Carbonic acid formed by the interaction of water and carbon dioxide in the tubular fluid that is dissociated in the tubular epithelium by the action of carbonic anhydrase into hydrogen ions and bicarb. The hydrogen ions are exchanged for sodium ions. So the hydrogen ions move back into the tubule and the bicarb is reabsorbed into the capillary. And the hydrogen ion is exchanged for sodium ion. So some of the sodium reabsorption is happening through this mechanism as well. So there are many things going on at the same time. This particular mechanism is the site of action of the diuretics that we call carbonic anhydrase inhibitors, because by inhibiting the action of carbonic anhydrase and disallowing this reabsorption of bicarbonate, we keep sodium and hydrogen ions from exchanging, limiting sodium reabsorption. So sodium stays in the luminal fluid, in the tubule fluid, and with it goes water. And so carbonic anhydrase inhibitors are diuretics, make you pee more. After the proximal convoluted tubule, we get to the loop of Henle. And the loop of Henle is extremely important in decreasing the volume of urine and concentrating it, although it actually comes out of the loop of Henle at a lower osmolality than it enters. But it removes tons of water and salt from the filtrate. This is done by a mechanism that is called counter current transport. So the descending loop of Henle is very permeable to water, and the ascending loop is not. How is the descending loop permeable to water? It has channels or pores, aquaporins, that allow the passage of water by osmosis. And so, because of a set of transporters in the ascending loop that are pumping massive amounts of sodium, potassium, and chloride out of the tubule fluid and into the interstitium, with no water going with them in the ascending loop. This creates a osmolarity differential between the interstitium, which now has a high osmolarity because it has lots of salt, and the tubule fluid on the descending side. So if the fluid enters the loop of Henle at 300 and is entering this medulla interstitium, which has a increasing osmolarity, the interstitial fluid, up to about 1200. Fluid moves out through channels, aquaporins on the descending loop, and then has become very concentrated by the time it reaches the bend. And as it moves through the ascending loop, the salt is pumped out, the sodium, the chloride, and the potassium, which leaves a much lower volume of fluid, which reduces the osmolarity as we go away from the bend because we're pumping out solute into the interstitium. So by the time the filtrate has reached, which is now really coming to approach urine, by the time it reaches the end of the loop of Henle, the top of the ascending loop, lots of water has been removed on the descending side. Lots of solute has been removed on the ascending side, and the volume has been greatly decreased. And the osmolality now is actually a little bit lower than plasma osmolality. And this is the site of action of the diuretics that we call loop diuretics, like Lasix and furosemide, and they act on the triple transporter. So by blocking the triple transporter, they keep the salts from being pumped into the interstitium. They change the osmolality differential on the descending loop, so less water is reabsorbed and less salt is reabsorbed. Once the fluid reaches the distal convoluted tubule, even more sodium is being reabsorbed, and this is through a symporter on the apical side that is moving sodium and chloride into the cell. And then, of course, the sodium potassium ATPase. Sorry, that shouldn't be a negative on the potassium. So the sodium potassium ATPase on the basilar side, which is pumping sodium out of the cell into the interstitial fluid and ultimately into the capillary. The distal convoluted tubule is under the control of a number of hormones. So there's endocrine input. One of the endocrine inputs at the distal convoluted tubule, this means that these tubular epithelium cells have receptors for these hormones, right? You have to have a receptor for a hormone to have an effect. So this is the main site of the control of calcium ion concentrations. Parathyroid hormone acts on the epithelial cells of the distal convoluted tubule and causes calcium to be reabsorbed, so removed from the filtrate, and phosphate to be exchanged, so phosphate is moved into the fluid and is eliminated in the urine. Another hormone that acts in the distal convoluted tubule is aldosterone, which is made in the adrenal cortex because it's an adrenocortical hormone. And aldosterone causes sodium to be reabsorbed and exchanged for potassium. So aldosterone makes you bring sodium back in to the circulation, and potassium is moved out into the urine. There is a hormone produced by the heart that's called atrial natriuretic peptide that is activated by stretch receptors, mechanoreceptors in the atrium. When volume is high, atrial natriuretic peptide and also something called brain natriuretic peptide, ANP and BNP, are released and cause more sodium to stay in the tubule fluid and be excreted. Again, taking water with it, so kind of functioning as a diuretic. In the distal convoluted tubule, there are mechanisms that allow pH regulation by secreting hydrogen ions and ammonium. And then this is the site of action of the thiazide diuretics. And what happens in the distal convoluted tubule is that thiazide diuretics like hydrochlorothiazide block the sodium chloride symporter. And again, by inhibiting sodium reabsorption, more sodium leaves the body in the urine, taking water with it, thereby being a diuretic. So the theme here is that anything that blocks sodium reabsorption is a diuretic. As the fluid now moves into the collecting duct and collecting tubules, there continues to be hormonal action. And so in the collecting duct, aldosterone and vasopressin both have receptors, ADH, and therefore the collecting duct is important in sodium and water reabsorption. Now, I have mentioned a couple of times that there are many places in the kidney where sodium and water move together, and it's always true that if you move sodium, you move water. So if we keep more sodium in the filtrate, more water follows it, we have a diuretic action. If we move more sodium, if we reabsorb more sodium, more water follows and we increase volume or maintain volume. Here is a place where that's happening, but also water is moving independently of sodium. And if you think about it, that's also true in the loop of Henle. In the descending loop, water is moving by itself through water channels, through aquaporins on the descending loop. On the ascending loop, actually sodium is moving by itself. The two work together, but and the reason sodium is moving by itself there is there are no aquaporins or no water channels for the water to follow. But in the collecting duct, if we have aldosterone, we reabsorb more sodium and we excrete more potassium. Now, what happens to blood volume and to blood pressure when we're reabsorbing more sodium? Okay, you remember that if you reabsorb more sodium, you also if you can reabsorb water, it moves with it and blood volume goes up. But blood pressure can go up too. So excess aldosterone actually can contribute to high blood pressure. Aldosterone causes increased expression of the sodium potassium ATPase and also of sodium channels in the lumen that allow sodium to move. Separately, ADH, antidiuretic hormone. What antidiuretic hormone does is it increases the expression of aquaporins. So the more water channels we have, the more water can move out of the tubule and back into the capillaries. So antidiuretic hormone inhibits diuresis. It takes water out of the urine. And in the absence of ADH, if you have no ADH, you can't move water here in the collecting duct, and therefore the water stays in the urine. So if there is ADH, we are reabsorbing water. If there is no ADH, we are not removing water here. And there are medical conditions where we make excess ADH, right? So in the syndrome of inappropriate ADH, SIADH, we absorb lots of of water, and we don't pee things out, and our sodium levels go down because this is a place where water is moving independently of sodium. In the absence of ADH, which is a condition called diabetes insipidus, water stays in the tubule and we excrete a considerable amount more water than we should be, and we'll get dehydrated and sodium levels will rise. And there are other things going on in the collecting duct. So we have movement of other ions, including hydrogen ions and bicarb. Now, we're going to come back in our next lecture on acid-base physiology to talk a bit more about the handling of bicarb and hydrogen ions in the kidneys. I glossed over that for this lecture because it's so important in the acid-base lecture. And at this moment, I want us to take a minute to kind of start looking at the forest instead of the trees. We've been looking at the details, and now we're going to come out and look a little bit at the big picture. So a huge part of the big picture of the kidney's role has to do with volume control, and I've talked about that on and on, but here we're going to talk about it a little bit more broadly in the sense of more holistically. So there are a number of inputs that help the kidney maintain volume control and influence blood pressure. And as I've said earlier, we change the amount of water and salt that we ingest. We have days where we drink tons of water and don't eat a lot of salt. We have days where we eat bunches of potato chips and don't drink enough water. In spite of all of that, our blood volume stays pretty close to the same. And a lot of that has to do with sodium reabsorption in the kidney. Under all normal circumstances, if the kidneys are working, the amount of sodium we take in a day has to be gotten rid of every day, right? If we're at homeostasis and we eat 3 grams of sodium, we have to excrete 3 grams of sodium, because otherwise our sodium level would go up, it would hold on to water, our volume would go up, we'd blow up. So as I've said before, there are places in the nephron where salt, sodium, and water move together, and there are places where they are handled separately. So let's review. We've already talked about some of these, but I'm going to talk about them again and talk about them together. The factors that influence the reabsorption of sodium and of water. One that we've talked about now a couple of times is that when the baroreceptor mechanisms in the aortic arch, and particularly at the carotid bifurcation at the carotid body, um, detect a decrease in mean arterial pressure, so a sudden drop in pressure, we get a massive sympathetic output. And that sympathetic output causes constriction of arterioles, lots of places, but one of those places is in the afferent arteriole, and that decreases filtration. So you are vasoconstricting the entering arteriole, dropping the pressure in the glomerulus, decreasing filtration, and therefore allowing more time for sodium to be reabsorbed as the filtrate moves through the nephron, and particularly in the proximal convoluted tubule. So think about that, make sure that makes sense to you. The next set of factors are these peptides that are essentially hormones: atrionatriuretic peptide ANP and brain natriuretic peptide BNP. Now, BNP is one that we use clinically, and I'll just tell you that it's something that you measure in when you suspect congestive heart failure, because the presence of excess BNP suggests that the atria is responding to an increase in volume, and therefore that there is a problem with congestive heart failure, that the heart is not managing the volume. So ANP and BNP are secreted by the atria, and they vasodilate the afferent arterioles and vasoconstrict the efferent arterioles. And what that does is increase filtration. So more fluid is going through and giving it less time to reabsorb as it moves through. So sodium reabsorption in the distal collecting tubule and collecting ducts is decreased. So what would that do to glomerular filtration rate? If we are vasodilating the afferent arterioles and vasoconstricting the efferent arterioles and increasing pressure in the glomerulus, which is a factor that promotes filtration, this is going to increase glomerular filtration rate. And by increasing glomerular filtration rate, getting rid of more water, reabsorbing less salt, what's going to happen to volume? Volume's going to go down. Another thing that ANP and BNP do in the kidney is they decrease renin production. So they have an effect on the juxtaglomerular cells that make renin. So here we have a diagram that is showing the stretch in the atria from cardiac distension causing the release of ANP and BNP, leading to vasodilation, dropping blood pressure, decreasing renin, increasing GFR. By decreasing renin, we decrease the production of angiotensin II and aldosterone, and all of that contributes to diuresis, which decreases blood volume, which decreases blood pressure. So these things are all working together with a increase in volume causing cardiac distension to counteract all of it. And then there's the renin, angiotensin, aldosterone system. And that's sort of the opposite. It's activated in response to a decrease in mean arterial pressure, or at least a decrease in renal perfusion. There are cells in the kidney called juxtaglomerular cells that are endocrine cells and that release renin when they detect decreased perfusion and decreased oxygenation. Renin then circulates and it interacts with angiotensinogen, which is a protein made by the liver, and it cleaves a peptide off of angiotensinogen, making a hormone called angiotensin 1. Angiotensin 1, now circulating, encounters enzymes primarily in the lung capillaries but also in the kidney capillaries that again cleaves off a couple of amino acids, and that takes angiotensin 1 to angiotensin 2. And angiotensin 2 has a couple of effects. It is first a potent vasoconstrictor, so it's making arterioles constrict to try to increase peripheral resistance, try to increase blood pressure because we have dropped pressures and we're responding to drop pressures and trying to maintain homeostasis. But angiotensin 2 also tells the adrenal cortex to release this hormone called aldosterone, and aldosterone stimulates sodium reabsorption. So we are now holding on to more sodium, bringing more sodium out of the fluid back into the system along with water. In addition, angiotensin 2 acts on the hypothalamus to stimulate the release of ADH, or antidiuretic hormone. And then that causes the formation of aquaporins. So again, more water can move out of the collecting tubules and back into circulation. And all of this helps to maintain normal volume when blood is lost or there's some other reason why pressures are very low. This can be a problem, and we talked about this in cardiovascular, when perfusion is poor because the pump isn't working. So the kidneys perceive low volume and they work really hard to increase volume, but because the pump isn't working, that increased volume only contributes to the pathology of congestive heart failure. Also, in many individuals, if the renin-angiotensin-aldosterone system is overactivated, it contributes to hypertension. And that's why a number of antihypertensive drugs are targeted to pathways in the renin-angiotensin-aldosterone system. One of the older ones, probably before we well understood the renin-angiotensin-aldosterone system, is spironolactone. Spironolactone is another diuretic, and it works by antagonizing aldosterone. Again, keeping us from reabsorbing sodium, and therefore sodium leaves the system in the water, and it works on the sodium potassium exchange countertransporter, and that means that as we are reabsorbing, let me take that back, we're reabsorbing sodium, but we're also actually holding on to potassium. Spironolactone is okay. So many antihypertensives have effects on all of these pathways. One of the older ones is spironolactone, which is an antagonist to aldosterone. And by antagonizing aldosterone, it causes us to reabsorb less sodium. That is partly through the sodium potassium countertransport, so we actually hold on to potassium. And unlike many diuretics, spironolactone does not cause potassium loss. It is considered a potassium sparing diuretic. Other antihypertensives that work on the RAS system are ACE inhibitors and angiotensin receptor blockers, and you'll learn all about these in pharmacology. And I think I've shown you either this slide or something very similar before, but basically we have something going on causing a decrease in renal perfusion, resulting in release of renin from the juxtaglomerular cells in the kidney. That renin acts on angiotensinogen that's produced in the liver, cleaving off a few acids leading to angiotensin 1, which interacts with pulmonary and renal capillary endothelium, encountering angiotensin converting enzyme or ACE, converting it to angiotensin 2 by cleaving off two more amino acids. Angiotensin 2 does a lot of things. It triggers sympathetic activity. It acts on the kidneys, triggering sodium and chloride reabsorption, water retention, potassium excretion. It interacts with the adrenal cortex, causing aldosterone secretion, which again is causing more sodium to be reabsorbed, more water to be reabsorbed, and more potassium to be excreted. It acts directly as a vasoconstrictor, and it triggers release of ADH from the pituitary gland. And we'll talk a little bit more about how that happens when we get to endocrine. But ADH is made in the posterior pituitary. And it is released, again, acting in the kidney by making aquaporins, which allow more water to leave the tubule and be preserved. So all of those things together cause water and salt retention that increase effective volume and feedback on the juxtaglomerular apparatus by increasing perfusion and decreasing renin production. This is a diagram again showing sort of the chemical actions. So we have angiotensinogen, renin acts on it, cleaves off a peptide. We now have angiotensin 1. It encounters angiotensin converting enzyme, which cleaves off a couple more amino acids, creating angiotensin 2. Angiotensin converting enzyme inhibitors like lisinopril, ACE inhibitors, act here, preventing the angiotensin converting enzyme from converting angiotensin 1 to angiotensin 2. Angiotensin receptor antagonists actually interact with the angiotensin 2 receptors, preventing the angiotensin 2 from binding and inhibiting the action of angiotensin 2. I'm giving you an example of an increase in blood volume. So say you are a normal person and you go to a ball game and you eat a couple of hot dogs and a bunch of popcorn and you don't drink the beer. So you have this increase in blood volume from the increased sodium intake. The carotid baroreceptors slow because as those baroreceptors detect stretch, they inhibit sympathetic output. And we have some relaxation of the afferent arterioles, and that increases glomerular filtration rate. And that down regulates the RAS system. We make less renin, we reabsorb less sodium, we make less ADH, we have fewer aquaporins, so we have less water reabsorption, and the sodium and the water both leave in the urine, and we pee a lot, and volume goes back to normal. Now, in a less healthy organism, so say somebody has congestive heart failure and they take in that big salt load, because they have the decreased renal blood flow from the lack of perfusion because the pump isn't working, these mechanisms don't work, and we hold on to sodium and water because we have this ongoing activation of the RAS system. And this is when somebody with congestive heart failure with a salt load suddenly gets much worse because their volume goes up. Here's another example, a backwards example. So nobody's going on cruises right at the moment. One of the reasons I quit going on cruises long before the era of COVID-19 was the idea of getting norovirus on a cruise. It just sounds absolutely dreadful. So suppose you get infected with norovirus and you have bad nausea and vomiting and diarrhea. You're losing lots of water, you're losing some electrolytes, you're losing hydrogen ions from the stomach acid from the vomiting, and you're losing bicarb ions because diarrhea fluid tends to have a lot of bicarb in it. And you'll understand that more when we get to the GI section. Remember, this all works together. So, volume is down because it's hard to drink much when you're vomiting. And therefore, those stretch receptors are not being activated, and that's going to trigger a sympathetic output. You're also going to have lower pressure at the glomerulus, and so there's less filtrate. You're going to activate RAS, you're going to make ADH, and all of those things are going to cause you to reabsorb as much salt and water as possible to try to maintain your volume, keep your volume from going down anymore. So you'll make as small a volume of urine as possible. So you have very concentrated urine. Now, if you are able to rehydrate and take in electrolytes, and this could be oral rehydration fluid or just oral fluid, you need water and salt and maybe some glucose to help you absorb it, or IV fluids. And so once you're rehydrated and the virus has passed and the symptoms are over, we re-achieve homeostasis. The next concept is something that we haven't talked about and is extremely important clinically. It's the concept of renal clearance. So bear with me a little bit and I'll get to why this is clinically important. There is something we call creatinine clearance that is clinically important. So let's talk a little bit about just sort of the idea of renal clearance. Renal clearance is defined as the volume of plasma from which some substance, and there are different substances that we can determine the clearance for, but which some substance is removed by the kidney in a minute. And the removal of the substance can involve, well, has to involve filtration. Well, doesn't. The substance may filter at the glomerulus, it may be reabsorbed, in which case it is not cleared, or it may be secreted, which may increase clearance. And it is measured in milliliters per minute because it's a volume of plasma per minute. There is a substance called inulin. Inulin is a starch-like substance, a polysaccharide, that is both freely filtered and neither secreted nor reabsorbed, meaning that inulin enters the glomerular fluid and passes through it with nothing else happening. And so all inulin that is filtered is eliminated in the urine. And if about a fifth, say we've said that about a quarter to a fifth of the blood volume goes to the kidneys, about a fifth of that is filtered, and all of that inulin is eliminated in the urine. So it's milliliters per minute, and it's exactly the same as glomerular filtration rate. Okay, so if we're filtering 125 milliliters per minute of fluid altogether, and there is inulin in that fluid, the Inulin is cleared at 125 milliliters per minute, and the GFR is 125 milliliters per minute. Glucose is kind of the opposite. Glucose is freely filtered. Glucose easily crosses into the urinary space, but under normal circumstances, all of the glucose is reabsorbed. So the glucose clearance is 0 milliliters per minute because it's all reabsorbed. None of it ends up in the urine. There is a substance that is not used clinically but is used by physiologists called para-aminohippuric acid that is used to test renal plasma flow. It's freely filtered, plus all of the rest. So if a fifth of the plasma fluid volume ends up in the urinary space, 4/5 of it ends up leaving through the efferent arteriole, but all of the rest of the PAH is secreted out of the peritubular capillaries and into the urine. And 100% of the PAH is eliminated, and it's used to estimate renal plasma flow. So it would give you an idea of what 100% of how much plasma is making it through the kidneys. It exceeds the glomerular filtration rate. It's about 5 times the glomerular filtration rate. So that brings us to the clinical concept of creatinine clearance. You can use inulin to measure glomerular filtration rate, but nobody does it, right? So we have other ways to estimate glomerular filtration rate. There is a substance called creatinine, and creatinine is a byproduct of muscle cell degradation, and muscle cells are constantly remodeling, and therefore there's always some creatinine being produced. And it is filtered at the glomerulus, usually maintaining a pretty stable value in plasma. So a normal creatinine, we will say, is about 1 milligram per deciliter. People who have a lot of muscle mass normally have a slightly higher creatinine. People with less muscle mass have less creatinine. So kids have lower creatinines. It is similar to inulin in that none of it is reabsorbed. So all of the creatinine that ends up in the filtrate ends up in the urine. However, a little bit of it is secreted, which means that when we estimate creatinine clearance, or when we estimate glomerular filtration rate based on creatinine clearance, it's going to be a slight overestimate because we're not just looking at glomerular filtration, but at this additional relatively small amount that's secreted. However, if we measure a serum creatinine and then how much creatinine is eliminated in the urine over 24 hours, we can calculate the creatinine clearance and use that to estimate glomerular filtration rate. And it's close. It's a slight overestimate. But in kidney disease, as we destroy glomeruli, and we're filtering less creatinine because we don't have as many glomeruli working, but there's still some secretion. The overestimate actually gets worse. So here's some math, and I don't think I'll make you use this math on an exam, but I do want you to go through it till you kind of understand it. We measure creatinine clearance by doing a couple of things. We collect urine for 24 hours. That means you pee and toss that pee in the first early morning, and then you collect all of the urine that you eliminate during the day in a jug, and including the next morning's first urination. So you have 24 hours of urination in a jug, maybe a gallon of urine, maybe less. You take it to the lab and your blood is drawn and a serum creatinine is measured. Okay? And that should be in the neighborhood of 1. There are different normal values for creatinine clearance in men and women having to do with size. But we determine we take that urine, we now have a serum creatinine, we have a volume of urine, and we can measure creatinine in the urine and determine the total amount of creatinine that is eliminated using the urine creatinine and the urine volume. And we then can calculate glomerular filtration rate. So glomerular filtration rate times serum creatinine is the same as the urine creatinine times the volume. And we use a little algebra. Glomerular filtration rate is equal to the urine creatinine times the volume, so the amount of creatinine that was eliminated divided by the serum creatinine. Now, that's how we actually get a glomerular filtration rate. 24-hour urine collection, serum urine. So if you don't, it's going to be wrong if the urine volume is not complete. So this is a test that it's pretty important to explain why you're doing it and what we're doing to get it to be right, and make sure that you have a complete 24-hour urine collection. We can also estimate creatinine clearance, and there are a number of ways. The way that is often in physiology books is something called the Cockcroft-Gault equation. It's actually a little bit out of date, but it's a formula that was determined by a couple of physicians in the 70s that is based on age and weight and gender, because we know that creatinine clearance is a little different in men and women. So the Cockcroft-Gault equation is 140 minus age times the weight in kilograms divided by 72 times serum creatinine, with a correction for women. And there are other formulas, but if you were to get on your phone and look it up, you could look up a creatinine clearance calculator. And a lot of people, I think this is a useful tool. There are all kinds of medical phone tools, but here I have assorted potential calculators. There's the Cockcroft-Gault equation at MD Calc. There are a couple of creatinine clearance calculators at the Medical College of Wisconsin. So find one that's helpful, and when you see a patient that you have concerns about whether their creatinine clearance is abnormal, whether their glomerular filtration rate is low because they have kidney disease, you can at least get a guess until you get a chance to do a 24-hour urine connection. Just back again to the kidney and acid-base balance, what we'll talk about a lot more in the next lecture. We maintain our plasma pH within a very narrow range, very close to 7.4. And when the pH falls below this range, it's called acidosis or acidemia. And when it's above that range, it's alkalosis or alkalemia. Um, the kidney steps in when pH is either high or low by doing a couple of things. It either excretes or reabsorbs hydrogen ions, and it either reabsorbs or retains bicarb ions. There aren't transporter proteins for bicarb ions. In addition, the kidney can make ammonium, and it buffers acidosis. And we'll come back to all of this and talk about the specific mechanisms in the next lecture. But I want to move on. I have two cases, and actually both of these cases are based on patients that I've seen. This is not a picture of my patient. But the first is Jacob, who is a 15-year-old high school wrestler, and his mom brings him into the clinic because she thinks he's having an allergic reaction. His face is swollen, his hands are swollen, his eyes are swollen, almost shut, and it's gotten a lot worse over the past week. She's been giving him some Benadryl, and it hasn't been doing anything. And his vital signs are a little concerning. His blood pressure's up a little bit. And we've seen Jacob before. He's a healthy kid. He's a healthy, muscular kid, in spite of my kind of nerdy looking kid picture there. He has mild to moderate edema all over. It's pitting edema. But he has normal cardiovascular and pulmonary exams. He doesn't have any pulmonary edema. And we do some labs, and he has a mild anemia, and his urine is quite abnormal. It's pink. It has 3 plus protein, 2 plus hemoglobin. And there are cells when we look under the microscope. And we check other things, like we do a big panel, and his serum total protein and albumin are low. Why do you think his serum total protein and albumin are low? Well, he's losing quite a lot of protein in his urine. And so, even though his liver's okay and is making protein, he's losing it in his urine. His serum creatinine's not too bad. It's at the upper limit of normal for adults, but we have previous labs on Jacob, and it was previously 0.8, so which would be more normal. And his BUN is normal, blood urea nitrogen. So his kidneys are still doing a reasonably good job of eliminating urea. We collect a 24-hour urine. We know we're going to refer this kid to nephrology, but we collect a 24-hour urine to estimate his glomerular filtration rate. And his volume is 2 liters. There is a lot of protein in it. I think 8 grams is extremely abnormal. We compute his glomerular filtration rate, and if I'm remembering, it was 60 or something. It was a little low. And nephrology, we referred him to Chapel Hill, to pediatric nephrology, and he was seen, scheduled for kidney biopsy. And his biopsy revealed something called IgA nephropathy, which is one of the autoimmune conditions that causes some glomerular loss and leaking at the glomeruli. So his podocytes aren't blocking the passage of albumin at the glomerulus, which is why he's losing a lot of albumin. He gets steroids, so he gets high dose prednisone, and he's advised to avoid strenuous physical activity. And over the course of the next couple weeks, he quits losing a lot of protein. His edema responds to that because he's now uh, got normal plasma oncotic pressure, so he's not leaking lots of fluid into the tissues, and steroids are weaned. And I will tell you the end of this story is that this kid really, really wanted to go back to wrestling and managed to go to an urgent care and have a instead of coming to his primary, which was me, he got his next sports physical at a different urgent care without telling them about the kidney disease because he was in remission. He didn't have the protein in his urine. They cleared him. He got slack because he was 15 or 16 about taking his prednisone, and before you know it, he was back in with edema and worsening renal function. And I don't know what happened to him after that. My next case is based on a guy that I saw. I don't go into a great detail, but it was a gentleman in his early 40s who'd had insulin dependent diabetes since childhood, since he was 13. And he didn't have insurance most of his life, worked as a carpenter, and he had managed his diabetes with over the counter insulin, which is regular insulin. Um, it has gotten more expensive. It used to be quite cheap, and so insulin and syringes were available over the counter at the pharmacy. He worked to keep his blood sugar under 200. The reason he initially came in to me is because he had walked on hot sand and he had burns on the bottom of his feet. And this is because he had decreased sensation. Okay. But in this case, we'll say that he is here because he recently got health insurance. And he's getting up about twice a night to urinate. He mentions that he is slower to heal than he used to be, and his only medicines are insulin and Motrin, OTC, Advil, Motrin. He is actually got a low BMI. I mean, it's normal, but it's low normal. He's hypertensive. Oxygenation is normal, heart rate is normal. He looks thin and tired, but he's in no distress. His exam is normal except for neuro exam, which reveals that he has very decreased sensation in a stocking pattern in both feet and ankles. And he has decreased vibration sense. And these are both indicators of a fairly typical diabetic neuropathy, peripheral neuropathy. And in this case, he has no open wounds. He has a little bit of athlete's foot. So, what are the labs that we should do on this gentleman? And you have not had lab medicine at all. Oh, I didn't mention back to Jacob. The reason he's anemic is because his kidney damage is starting to impact his erythropoietin production. Okay, but now we're to Mr. Hoffman. So, what labs should we do? I certainly want to do a blood sugar now. I'm also going to send off a comprehensive metabolic panel looking at his blood sugar and his kidney function, along with the electrolytes, sodium and potassium and calcium, and all of those things. And I'm going to get a test called a hemoglobin A1C. And hemoglobin A1C is a way that we measure kind of average blood sugar over time. I already touched on why his feet are numb. One of the long-term complications of elevated blood sugar, very common in people with long histories of type 1 diabetes, is peripheral neuropathy. Sometimes it's painful, sometimes it's simply loss of sensation. And we are concerned about a number of complications of diabetes. One of the problems with peripheral neuropathy is that people with peripheral neuropathy tend not to be aware when they have wounds on their feet and end up with serious ulcers that can progress to deep infections that result in far too many cases still, and this is both type 1 and type 2 diabetics, ultimately in amputation because the infections get beyond the ability to manage with debridement and antibiotics. I want to just briefly touch on Mr. Hoffman's Motrin. Lots of people take Advil and Aleve and ibuprofen and naproxen for arthritis. It's over the counter. That must mean it's safe, right? Well, for Mr. Hoffman, maybe not so much because if you remember, prostaglandin inhibition can affect blood flow to the kidneys and actually decrease glomerular filtration rate. And one of the serious complications of diabetes, again of prolonged diabetes and elevated blood sugars, is kidney disease. And diabetes is I believe in the United States, the most common cause of kidney failure, dialysis, um, and serious kidney disease. Transplant cures that, but if you're diabetic and you're not controlled particularly, that it's just going to happen again. And Mr. Hoffman needs to be advised that he should take acetaminophen for his arthritis pain because acetaminophen does not have the same effects on prostaglandins that ibuprofen has. And here we show the glomerular hydrostatic pressure and how the afferent arteriole is vasodilated by prostaglandins, allowing increased blood flow. And if we reduce prostaglandin synthesis by the use of NSAIDs, our afferent arteriole constricts. We have decreased pressure in the glomerulus, in the glomerular capillaries, decreased filtration into bone and space. In addition, one of the things that we do for diabetics, and I'll talk about this on the next slide. Well, I'll come back to it. How about we do that? Here we have his labs. His blood sugar is not that far from what he said he tries to maintain it at about 200. His urine shows some glucose and some protein, so he is exceeding his proximal convoluted tubule's ability to reabsorb glucose. He has some glomerular damage that's resulting in the loss of some protein. His hemoglobin A1C is 9.2. We look at a chart and see that in fact a hemoglobin A1C of 912 is very much suggestive of an average glucose around 200, which is quite high. We want it down in the between 100 and 150. Glucose goes up and down. Fasting glucoses are usually under 100. His creatinine is elevated and his BUN is elevated, so he has significant kidney damage as a result of his diabetes. If we use the Cockcroft-Gault equation to estimate his creatinine clearance, 140 minus his age times his weight in kilograms divided by 72 times his serum creatinine results in a value of 27.4. And remember we talked about creatinine clearance or glomerular filtration rate being in the neighborhood of 125 milliliters per minute. This is 27.4 milliliters per minute. I did not put all of the I did not put all of the units in here that we could, cross them out and come out with 27.4, but it's 27.4 milliliters per minute. It's going to be important to verify this with a 24-hour urine collection and a GFR calculated based on the urine and serum creatinines and volume. However, that is going to be a slight overestimate. We categorize kidney disease by stages, and stage 1 is normal. So it's not kidney disease, or it's kidney disease with a normal or increased glomerular filtration rate. A mild reduction in GFR is stage 2. We divide stage 3 into A and B, so 30 to 60. Stage 4 is a severe reduction, 15 to 29, and that is where our gentleman falls at 27.4. And people who have reached stage 5 kidney disease are said to be in kidney failure with a glomerular filtration rate of less than 15 mLs a minute, and they require dialysis. We manage diabetes, type 1 diabetes, and there are similarities with type 2 diabetes, but this gentleman has type 1 diabetes. It's always important with diabetics to manage their blood pressure because the combination of hypertension and high blood sugars is extra bad for the kidneys. Plus, as you know, the kidneys are important in the control of blood pressure, and so kidney disease is going to increase blood pressure. So we have to work to make sure his blood pressure is normal. One of the antihypertensives we're going to give this gentleman is an ACE inhibitor because, in addition to bringing down his blood pressure, ACE inhibitors help to protect the kidneys by blocking RAS and decreasing glomerular pressures. And here's where I'm going to go back up to that other slide. So, vasoconstriction of the efferent arteriole is mediated by angiotensin II, and ACE inhibitors reduce the production of angiotensin II from angiotensin 1. And if we reduce the production of angiotensin 2, we're going to improve the ability of the kidney by just reducing glomerular pressures. And then insulin. There are lots of medicines to control glucose in type 2 diabetes. In type 1 diabetes, it's insulin. However, there are lots of kinds of insulin. Regular insulin, which is short-acting insulin, works, but it has to be given very frequently, which can become quite difficult to be checking blood sugars and computing insulin doses and giving insulin 4 or 5 times a day to maintain fairly normal levels. Plus the difficulty in maintaining normal blood sugars overnight when you're going many hours without checking blood sugars. But there are many newer insulins that have more prolonged times of action and allow us to control blood sugars through the course of the day with fewer injections, 1 or 2 injections a day in many cases. Insulin pumps are very helpful for some people because they allow us to administer insulin without an injection, again requiring frequent blood sugar checks, but improving the ease of managing. And by managing blood sugars, we can slow the development of complications like neuropathy and eye damage, diabetic retinopathy, which is a vascular eye complication, and the kidney disease that's caused by diabetes. There is a lot of research currently on transplanting not a whole pancreas because that's a big deal and not easy. Um, but transplanting, and it is done in some cases, but transplanting pancreatic islet cells, which means taking islet cells, isolating them, and then injecting them such that they lodge in places where they are able to kind of grow into an islet and produce insulin. But this is still experimental. May be something that will become more important during your career, may not. How do we treat severe kidney disease? Well, when people get to the point of end stage kidney disease, they need dialysis because their kidneys aren't able to do all those functions of the kidneys. And we divide dialysis into two basic types. There is hemodialysis, which uses a machine, and peritoneal dialysis, which actually uses the peritoneal membrane. During dialysis, we are able to remove excess salt and water, returning volume to normal. Because, as you can imagine, if you're not making urine, you're not peeing, volume increases, and that can become a problem. Can result in pump failure if it gets too high. And the main way that that happens is through something called ultrafiltration, that the pressures on the blood side are higher than the pressures on the other side of the semi-permeable membrane. And so they push some excess water and salt out of the blood into the fluid that is called dialysate. That fluid has various substances in concentrations that are intended to help return to homeostasis. The sodium level is usually normal. The potassium level is usually lower because people who are unable to eliminate excess potassium tend to have high potassiums. There's no urea in dialysate, so that urea will move out of the blood and into this fluid. And then there is a semi-permeable membrane. So there's fluid and a semi-permeable membrane across which substances either diffuse or ultrafiltrate. And this allows the removal of toxins like blood urea, nitrogen, urea, and excess potassium. So we are removing primarily water, sodium, potassium, and urea. These diagrams show this is a typical dialysate. We've said normal sodium is 140, normal potassium is 4.5. We don't want to drop potassium too low, so in dialysate, typically potassium is about 2. There is bicarb in dialysate. There is bicarb in blood, but it is expressed as carbon dioxide level CO2. BUN in blood, urea, none. Creatinine in blood, none. Glucose could be at 100. It's usually a little higher than 100. And this is just to keep from accidentally making the person hypoglycemic. Calcium, there's usually higher calcium in dialysate. No phosphate, because remember that calcium is mostly reabsorbed and phosphate is mostly eliminated. And then there's albumin in blood, but there's no albumin in dialysate. In the dialyzer, and this is the dialysis machine, basically blood enters the machine and is passed through a chamber where there is a semi-permeable membrane with dialysate on the other side. There's higher pressure here, so the ultrafiltration pushes some of the water and salt across the membrane, because really water and salt are in very similar concentrations, but pressure moves them, while diffusion moves the substances such as urea and creatinine and potassium and phosphorus from the blood side of the membrane to the dialysate side. And the dialysate is being moved so that the waste is removed and fresh dialysate is there to maintain those low levels of the substances that we need to move across, and the blood is then returned to the body. This is a dialysis machine showing the individual hooked up with a tube leaving and a tube returning to the body. Dialysis is usually 3 times a week for 3 to 4 hours a session, so it takes about 12 hours a week of your life. People who do hemodialysis may carry on with normal activities and normal jobs, but it does take a significant amount of time. There are people who have dialysis machines at home. It is requires some more teaching. It can be a little bit more difficult for some individuals. On the other hand, there are people who live in the willy wags, so to speak, who aren't close to a dialysis center for which home dialysis might be more helpful. And there are people who may have more difficulty getting to a dialysis center because of disabilities. So, dialysis center or home for hemodialysis. Here we're showing the shunt. Basically, people who get hemodialysis need a surgical procedure in which an artery and a vein in their arm are connected, which allows for increased pressures on the venous side that make the veins dilate significantly. And that creates the a vessel with enough diameter and blood flow to be able to easily remove blood and return blood to the system. Now, peritoneal dialysis is the other kind of dialysis, and in peritoneal dialysis, the semipermeable membrane is actually the peritoneal membrane. And so essentially, the dialysate is using gravity for people who do ambulatory peritoneal dialysis. Dialysate is put in to the abdominal cavity through a catheter that has been surgically inserted. And it looks to me like this fellow has had his catheter moved a couple of times. So this may be a new catheter. After it has had time to be in contact with the capillaries that are within the peritoneal membrane, and diffusion has occurred, the dialysate is drained and discarded, and then new dialysate is infused. So this can be done every 3 hours throughout the day as people go through their normal activities, or it can be done by a machine at night. So instead of gravity, there's a pump, and dialysate is infused and left for a few hours, and then pumped out, and new dialysate is infused and left for a few hours and pumped out. And then in the morning, dialysate is infused, and then at night, when the machine is hooked up, that dialysate that's been there during the day is removed, and there may be one exchange during the day. And I just found this and thought it was pretty funny. Dialysis is complicated. We have pretty buttons, a gray thingy, a dial that turns, red, white, and blue buttons, roly things. And I would like to say that I have a sister-in-law, my brother's wife, Miriam, my oldest brother's wife, he's passed on now, who developed kidney failure as a result of an unknown glomerulonephritis. They never did determine the cause of her kidney disease, in the early 80s when she first came over from England and got married to Bob. And it got much worse after childbirth. She had a hemorrhage, and she was already in stage 3 or 4 kidney disease when she had a postpartum hemorrhage, lost pressures for a little while, enough to cause enough further damage to her kidneys that she entered end stage renal disease and was on dialysis for several years. Went to the dialysis center 3 times a week, made traveling to England complicated, or anywhere, because she always had to arrange for dialysis when she got there. And when her daughter was 4, which would have been in 1986, or maybe 385 or 86, she had a kidney transplant. Now, she had been on the list for about a year, and it was only in the early 80s that our ability to prevent immune rejection of kidneys was improving. Prior to that, the main drug that was used as an anti-immune drug was prednisone, but something called cyclosporin A was introduced. So she got prednisone, but also cyclosporin A. And she was fortunate enough to have a good enough match that it is now 2020. My niece is 38, and she's had that kidney for 34, 35 years and continues to be very active and very functional. So we are very grateful for kidney transplants and for dialysis, which was able to keep her alive and functioning during those early years of my niece's life. So that's it for today. I hope you enjoyed the lecture. And I am really looking forward to the acid base lecture that is coming up next.